Topic is development of midgut and anomalies. So in this we describe the competency, that is development and congenital anomalies of midgut. Midgut is the midgut in the 5 millimeter embryo is seen beginning just caudal to the entrance of the bile duct into the duodenum, terminating at the beginning of the last third of transverse colon. It is suspended from dorsal abdominal wall by short mesentery, and it communicates with yolk sac via the vitelline duct. Coming to derivatives of the midgut, the derivatives of midgut include small intestine except the first part of duodenum, that is up to the common bile duct entrance. Then cecum, appendix, ascending colon, right half to 2/3 or proximal part of transverse colon. These are supplied by superior mesenteric artery and nerve supply is vagus nerve. Midgut development is characterized by a rapid elongation of the gut and its mesentery. Initially, the midgut communicates with the yolk sac. This connection narrows to the yolk sac, or also called as vitelline duct. Elongation of the gut occurs faster than the elongation of the embryo body. A series of intestinal changes take place, usually in 3 stages. Physiological herniation. As it elongates, the midgut forms a ventral U-shaped umbilical loop of the gut. It is the primary intestinal loop that projects into the umbilical cord. Herniation takes place at weeks 6 to 10 and is a normal migration of the midgut into the extra embryonic coelom. It occurs because there is not enough room in the abdomen to accommodate the fast growing midgut due to the space occupied by the massive liver and the kidneys. Thus, at this stage, the intraembryonic and extraembryonic coeloms communicate at the umbilicus. Midgut develops entirely outside the abdominal cavity. Midgut has 2 limbs, proximal and distal limb. Yolk sac is attached to the apex of the loop at their junction. If the duct persists, it is called as Meckel's diverticulum. Proximal limb grows rapidly to form small intestine coils that include distal duodenum, jejunum and ileum. Caudal limb changes little except for the developing of the lower ileum, cecal diverticulum, the appendix, the ascending colon and proximal 2/3 of transverse colon. In the umbilical cord, the midgut loop rotates 90 degrees counterclockwise, seen from the front around the axis of the superior mesenteric artery, bringing the proximal limb of the loop to the right and distal limb to the left. Return of the midgut, reduction of the midgut hernia. During week 10, intestines return to the abdomen. Proximal limb, that is jejunum of the small intestine, return first and pass behind the superior mesenteric artery to the left side. The latter returning loops settle more to the right. Cecal swelling is seen in the 12 millimeter embryo as a small conical swelling of the caudal limb of the primitive intestinal loop and is the last part to re-enter the cavity. As they return, the cut undergoes another 180 counterclockwise rotation, placing the cecum and appendix near the right lobe of liver, from where they descend to the right iliac fossa at a later date. Thus, total rotation is 90 plus 180 is equals to 270. The return to the abdomen is related to the decrease in the relative size of the liver and the kidneys, as well as abdominal enlargement and expansion. Midgut malformations. Midgut malformations are common and may result from abnormal development of the digestive tube, incomplete rotation, or failure of fixation. More than one cause may be interconnected. The major clinical manifestation of malformation is the syndrome of neonatal intestinal obstruction. There are conditions like underdevelopment that include agenesis, that is complete absence of an intestinal segment. And another condition is Atracia and Stenosis. In this, an intestinal segment is and remains narrow and constricted, most often seen in the ileum. Then we have duodenal atracia, that is distal to the duodenal papilla. In this condition, vomitus always has bile. Polyhydramnios may occur with duodenal atracia. The cause is often failure of recanalization or interruption of the blood supply. Then overdevelopment, Omphalocele or Omphalocele are seen in 1 in 6,500 births, results from failure of the intestine to return to the abdomen during stage 2 of the midgut loop rotation. Loop remains in the extraembryonic coelom of the umbilical cord. Hernia can be a single loop of bowel or may contain most of the intestine as well as spleen, liver and pancreas. Hernial sac is covered by amnion of the umbilical cord. Eventration of the abdominal viscera or congenital umbilical hernia. A type of omphalocele is due to faulty closure of the lateral body folds during 4th week of embryonic life. Abdominal viscera develop outside the embryo in a sac of embryo. It is often associated with exostrophy of urinary bladder. Then gastroschisis is uncommon and is due to defect of the anterior abdominal wall with extrusion of the abdominal contents without involving the umbilical cord. Viscera protrudes into the amniotic sac and float in the fluid, usually seen on right side and is more common in males. Then anomalies of position, non-rotation, quite common, called left-sided colon. Generally it is asymptomatic, but twisting or volvulus can occur. Midgut does not rotate after it enters the abdomen. Thus, the caudal limb enters before the cranial limb. Small intestine lie on the right side and the entire intestine on the left. May cause obstruction of vessels and the gut if kinking or twisting occurs. Then volvulus and mixed rotation. Cecum lies below the pylorus and is fixed to the posterior abdominal wall by peritoneal bands that cross over the duodenum. Usually causes duodenal obstruction. Due to failure of the midgut loop to complete the final 90 degrees of rotation, thus terminal ileum may enter the abdominal cavity first. Reverse rotation is rare. Clockwise rotation, not counterclockwise. Duodenum lies in front of superior mesenteric artery and transverse colon behind it, which may obstruct transverse colon due to pressure from the artery. Small intestines lie on the left, large intestine on the right, and the cecum is found in the center. Then coming to cecum, subhepatic cecum, that is failure of the proximal colon to elongate during stage 3 of rotation. The cecum ends up near the liver. Mobile cecum, due to incomplete fixation of ascending colon, results also in a mobile and variable appendix and even volvulus of the cecum. Midgut volvulus, mesenteries fail to undergo normal fixation and the intestine twist with incomplete rotation of the midgut. Small intestine hang by a narrow stalk of superior mesenteric vessels and twist around it, thus obstructing at or near the duodenojejunal junction. Remnants of the wetland duct. Duct usually disappears at 6 weeks. Mecus diverticulum. It is an ileal diverticulum and most common malformation of the digestive tract in 2 to 4% of people. It is clinically significant because it can become inflamed and cause symptoms mimicking appendicitis. It is located 2 to 3 feet from the ileocecal valve. It is finger-like pouch, about 3 to 6 centimeters long, arising from antimesenteric border of the ileum. Its walls contain all the layers of the ileum, but may also contain gastric and pancreatic tissue. The gastric mucosa may secrete acid and produce ulceration, bleeding, and perforation. Then umbilical or wetland fistula. Wetland duct remains patent over the entire length, thus connects umbilicus and the intestinal tract. It may lead to fecal discharge at the umbilicus or ileal prolapse through the fistula. One may find the duct closed at both the ends and the formation of vitelline cyst in its mid portion. Congenital aganglionic dystony or megacolon, also called as Hirschsprung's disease, is rare, may affect the colon, small intestine or duodenum, but especially the rectum and its internal external sphincters. It causes a portion of the colon to dilate due to the absence of aganglionic cells of the meyenteric plexus distal to the dilated segment due to failure of the migration of the neural crest cells. Dilated portion itself has normal population of ganglionic cells. Dilatation is caused by failure of the distal segment to move the intestinal contents forward. The severity of the condition is directly proportional to the length of the gut segment involved. Mucoviscidosis, adherence of meconium to the intestinal wall, secondary to the deficiency of trypsin secretion by the pancreas as a result of the latter being invaded by interstitial fibrosis of unknown origin. Thank you.